Thank you so much for inviting me today. It's been an absolute pleasure for this first half of the morning. My topic today is on endometrial factors in implantation failure spectrum. And I'm going to give you a bit of an overview and then some of the new work we've been doing in the lab mainly, trying to look at some of the other causes and how hard it is to actually work out the causes of implantation failure. I do have some funding and conflicts of interest, but as you all know, if you work in IVF, implantation is by far the biggest barrier to pregnancy in IVF, and this is 2016 data, but about 60% of our embryo transfers don't result in a pregnancy. And so that's an issue for us, and it's the biggest heartbreak for our patients. It's the stage where things go wrong the most, and we know so little about it. This diagram has been taken from a diagram in another journal, but I've added a few more things. And there's lots and lots of different causes. So embryo quality and numbers are clearly a massive factor. Male factor, we don't talk about it much. I'm really lucky that we've got a session on it here because I think it is an area that we need to do more on, and we've got fabulous speakers for that too. We're getting better and better at the genetics and the lab culture. And we do know about lifestyle factors, but it's hard for our patients to moderate them. And then endo and adeno, we have traditionally diagnosed very poorly, but there's a lot of new work out there that we've been involved in too. And then autoimmune disease, we're actually really bad at diagnosing that. Infection is the same, we miss it a lot of the time, and again there's lots of new testing out there for that, and endometrial receptivity, and there's a lot of controversy on that at the moment. The issue is that we don't have very good definitions of what recurrent implantation factor is. This is one of the many, that you need 4 good quality embryos transferred in 3 cycles in people under 40. So that means by definition anyone over 40 doesn't have it, which just doesn't apply. And so we really do have a very broad definition. And in terms of miscarriage, we actually talk about numbers. If you've had 2 or less in the USA and 3 in the UK and Australia still, so you can have a different number and you get diagnosed differently. And we're diagnosing on numbers, not on causes. And I think we need to start changing that paradigm. Now we're getting better and better tests. So why do we define it by losses? And it's a real taboo area, miscarriage. People feel very uncomfortable talking about it. It's very disruptive on a relationship. It's very traumatic for couples. And yet we expect them to go through 2 and 3 before we actually do anything. And we say things like, it's natural, it wasn't a real baby, at least it was early, at least you can create embryos, next time it'll work. Sometimes things happen. And those statements are incredibly, incredibly difficult for couples to hear, and it really takes everything away from them often, particularly when they've had 2 or 3, and we often don't do anything about miscarriage until that point. Certainly, in some countries, you can actually have a leave now. If you have a miscarriage, you're entitled to 2 or 3 days leave, but many people miscarry at work, miscarry at a conference, nobody knows, and they're just sitting there going through that. And we're not really allowed to, it's a very big taboo to talk about it. They don't tell their friends, they don't tell anyone, and it's very isolating. But we actually can do quite a lot about it. We do have a lot of really good technology. A lot of it's about the political will to support investigation and to support treatment, and to understand the trauma, and part of that is about people explaining in public the trauma they've gone through. We can assess embryos. We're very good at PGTA now. We can often find normal embryos. We actually can assess the products of conception really well. And sometimes people have been doing a surgical procedure and we get a karyotype. It's reasonably successful, but certainly with CGH arrays and sequencing, even from medical miscarriages or natural miscarriages, we can actually amplify the DNA and get some DNA diagnostics for people. And knowing that a miscarriage was related to a chromosome in the wrong place gives people an answer. It wasn't the coffee they drank. It wasn't, when they did the wrong thing and they went out for dinner or something that they've blamed themselves for. It was something they had no control over. And we know that as doctors, but often it's very hard for patients to really get a true understanding of that. The other thing which is quite interesting is some of the early NIPT work that's happening in the miscarriage field, and certainly we are able to get some genetic answers much earlier than 11 weeks for many people. So there's no real reason, apart from cost, and these will come down in cost, that we can't give people better answers. It's just we haven't had that paradigm, and it's happened so often that we shouldn't be doing it. And I think we need to start changing that. When you take out the causes that would affect the embryo, which are genetic causes, male factor causes, chromosome causes through aneuploidy, we then end up with these kind of causes of miscarriage. And if you look at uterine structural anomalies, that's one cause, septums, polyps, and they're easily fixed. But you don't want to go and give someone steroid treatment if there's a polyp there. So doing a hysteroscopy is obviously very important. Autoimmune disease, we don't have great diagnostics. We need to get better. We need to work out how to actually measure these more accurately. Infection, we're not great at infection. We look for plasma cells. We don't. The endometrial environment often has factors that are hard to grow, and we need to get better. With endo, we've been terrible at diagnosing endo, and we're working on ways that we can do that better, which are much better. And then we are starting to actually look at when the endometrium is receptive. So the endometrium is usually covered by a glycoprotein layer, and when you start progesterone, about 5 days later that glycoprotein layer comes down and the embryo can actually interact and implant. And you can measure that with molecular techniques, looking at microRNA profiles, and there's also some immunostaining we can do. And we're figuring these things out, but all these things are very new, and we need to work out how to use them, but we also need to know that the embryo wasn't the cause. When you look at anticardiolipin antibodies, we do lots of tests. They usually come up negative, and it's because there's a lot of different ones. I read one paper that suggested there were about 40 of them, and our labs do one assay for one epitype. And so the sensitivity and the specificity isn't very high. And if you detect them, it's easy because you know what you're dealing with. But a lot of the time, I think we miss them. We're very bad at working out infection, although we are getting better. And it's because the endometrium is actually a very low biomass environment. So there's not many bacteria there. And most of them are anaerobes or fastidious organisms like chlamydia, which you can't grow on an agar plate, and obligate intracellular organisms. So we have looked at different things. Plasma cells are available, and you can do special staining, but most of the time we don't. We normally send it to the lab. They look at the picture on the left here, and they say there's nothing there, but actually the little yellow arrows show you the plasma cells, and unless you have a good histologist, you would need to do a stain. And then how many plasma cells do you need until you call it endometritis? I think the microbiome, there's a lot of work going on. I think it's a very interesting area, but it's expensive for us at the moment. And there's a lack of consensus about what is abnormal, and particularly dysbiosis, which is we've not detected an organism, but the environment, the microbiome group of organisms don't look right. We are getting much better at endometriosis, and we actually are running a program called Imagendo, where we have very expert sonologists who detect endo very well on scans. We also do an MRI, and on MRI, the iron in endometriosis lesions show up on the T1 picture, and if you put those together with AI, you can actually diagnose not everyone, and if you have a negative diagnosis, you can never say someone doesn't have endo, but it makes unexplained fertility problems quite rare in your clinic if you get a good diagnosis. And it also means you can target your treatments much better in IVF if you know someone has endo before you start, and there's very good evidence that that makes a big difference. This is the sliding sign. It means endo's not there. It's a positive sign, but it means it's not there. And it means the back of the uterus slides over the bowel. This is a negative sliding sign, and in fact you can see an endometrioma there as well. And it just doesn't move, and that's because endo is holding that down. Whereas in the MRI you get a completely different picture. And we've used a lot of AI with a lot of data images to put those two modalities together to improve diagnostics. And you can actually use one modality, they don't have to be paired data, to train the other modality, and you get better diagnostics as well. So there's a lot of really interesting work happening in AI around endometriosis. Most of the disorders we see of the endometrium are associated with inflammation. Lifestyle, if you smoke a lot, if you drink a lot, if you do a lot of marijuana, you get inflammation. And you have to modify that, obviously, is the way to treat that. Autoimmune, antiphospholipid antibodies attached to the lipids in the cell wall of the placenta create an inflammatory area, and that makes it hard for the placenta to grow. It causes a lot of inflammation around the placenta. Infection clearly causes inflammation, and endo and adeno potentially do as well. So we know that inflammatory endometrial disorders are really badly diagnosed. We don't diagnose antiphospholipid, endometritis, endometriosis, and we don't have a very good handle on receptivity. So we decide to measure immune cells, and that shows us that there's some inflammation there, but it actually really doesn't give us the cause. And then what happens is we diagnose, we find the immune cells are inflammatory and at high levels, and we use a whole lot of immune suppressants. And every single one of those things on my list I have seen a patient using. And some of those are really high-level anti-rejection drugs. And they're using them when the only thing they will treat is that. And if you haven't diagnosed the other things, endometriosis, if you give baboons steroids, their endometriosis gets a lot worse. They can't clear the cells. Infection will get a lot worse if you give immune suppressants. A lot of things will, the next thing I'll tell you about in a minute, also gets worse, so I'll explain that in a second. So I work with Sarah Robertson. She's one of the most world-renowned reproductive immunologists, and she's very involved in looking at reproductive immunology in the endometrium and placenta. And the paradigm we use, I'm sorry, I've just gone the wrong way, is that you need your immune cells. You cannot create a placenta without your immune cells clearing the path, removing cells in the road, and building structures for the placenta to grow. But what you need is a lot, let me just see if I've got this right, yep, is you need these immunotolerant cells. You need cells that are going to help you grow and remodel and heal that placenta so it gets bigger and bigger. And we like M2 macrophages. We do like uterine natural killer cells, but we want them to behave well. And when you have an inflammatory environment from whichever cause, they don't behave well. They become inflammatory, and you get M1 macrophages and cytotoxic natural killer cells. And when we measure natural killer cells, most of the time we don't measure how they behave, we measure their numbers. And what we believe is that if we have regulatory T cells or Treg cells, which are the remodeling phenotype and the immunotolerant phenotype, they activate the rest of the cascade of the immune cells to appropriately activate the NK cells. And we know you need them. They go very high in the luteal phase, and they stay high for the first 3 months when you remodel your placenta. We get M2 immunotolerant macrophages and tolerogenic immune cells, dendritic cells. And that means that you have these really good cells that you need outweighing any inflammatory immune cells, and that leads to a receptive endometrium, implantation success, and fertility. Whereas if you have an environment that's very inflammatory, you get T effector cells, which then cause underactivated or overactivated uterine natural killer cells that are cytotoxic, M1 pro-inflammatory macrophages that phagocytose and release things that will cause necrosis, and then immunogenic dendritic cells that create more inflammation. And that causes the endometrium to be less receptive, implantation failure, and infertility. And similarly, further on, when you talk about miscarriage, these are the kind of cells we need. We need the immunotolerant cells to all work together with the healing cytokines, which we can measure, to remodel the vasculature of the placenta. And then you get a really healthy placenta right from the very, very beginning. Whereas if you have an inflammatory environment, those blood vessels, they're so busy trying to deal with dying cells and apoptotic cells that they don't remodel the vasculature very well, and you get a shallow placenta and then miscarriage. And so that's the paradigm we've been working with. And the Treg cells really are the masters of the universe when it comes to uterine cells. They're the ones that decide whether all the other cells are going to, they signal to the other cells and tell them whether they're going to behave in a remodeling, healing way, or whether they're going to be inflammatory. And if we can get them to behave in a healing way, we're going to have a much better chance of helping our patients get implantation and then good placentation. We do not want them to have a miscarriage either. And it's sort of a little bit along the spectrum of both things. And these T cells are really important, and this is actually a wee bit out of my league because this is about much later in pregnancy, but this is other work that Sarah's done with Alison Kerr, looking at preeclampsia and small for gestational age and preterm labour. And these Treg cells are really important to suppress inflammatory things that happen in pregnancy so you don't go into labour early and you don't find the placenta doesn't grow very well. And so we really want to have these Tregs working well right from the beginning, and all the people in the room here are people that can change that for our patients right from the beginning. We see people before they get pregnant. And the question is, why don't we diagnose very well? What's going on, and why are so many people don't have any of these things and they still have issues with implantation and recurrent miscarriage? And I'm going to propose today and give you some evidence for the fact that high insulin levels are a marker for us that are very treatable, that can cause inflammation around the placenta and around all cells in our body actually, and that they're treatable and can potentially help us with both miscarriage and implantation. And so we asked the question, what about measuring insulin? We do know that certainly for recurrent miscarriage, there's quite good evidence that it's associated with hyperinsulinism is associated with recurrent miscarriage. And this is a meta-analysis by Kai showing the forest plot here that the people who had recurrent miscarriage were more likely to have high insulin. This is a kind of example of what we've been doing. We actually measure the 2-hour insulins as in a GTT. We ask people who have implantation failure or recurrent miscarriage or mid-trimester losses as well, or late losses, to not only do a GTT, which is our standard clinical practice, but to also do a 2-hour, a fasting and 2-hour insulin. And this person here, if we just did the GTT, you would have no idea their insulins were high. You wouldn't have a clue. There's actually quite a lot of clinical signs that you can actually ask people about that you would pick it up, mainly family history of diabetes, but you wouldn't know that they were actually very hyperinsulinemic. And then as time goes by, you start getting higher levels of glucose in the blood, and then the pancreas actually starts secreting less insulin, and then by the time you get to diabetes, you just haven't got the power to keep the sugars in the cells, and they spill into the blood. This is a miscarriage cohort that we have in Adelaide that was put together by Dr. D. McCormick. And in this miscarriage cohort of 474 patients, 66% of them had high insulins when you measured the 2-hour test. And that proportion, you could measure HOMA-IR, and it overlapped, but sometimes people had one or the other too. So there's an overlap, but it's not exclusive. Both of them give you a risk of gestational diabetes. And only 34% had normal insulin. So in an Australian population, this is a high level of people with high insulins in our cohorts. And what we actually worked out was that 43% of these people with high insulin will go on to gestational diabetes, which has significant morbidity in a pregnancy. And, you know, we can potentially look at this before they start and tell the obstetricians that this person's at high risk of getting gestational diabetes. Can you prevent it? Can you prevent the morbidity from it, which is even more important? And if you didn't have high insulins, you had a 9% chance of having gestational diabetes. So it's a really good marker for gestational diabetes. And what we really found was it was completely not associated with BMI. We could not find an association with BMI. We spend hours getting people to get their BMI down. And a lot of people don't have a high BMI, but they have a high insulin, and we are not treating those people. It is associated with ethnicity. So particularly if you're an immigrant to Australia, you're more likely to have high insulins. I'm one. And if you've got a family history. So the single best question you can ask is, do your parents or your grandparents have diabetes, and or have they been tested for it? The reason we went down this path was we did a lot of work in the lab, and this is Hannah Brown's work, where she looked at putting at mouse models where they had high glucose or high insulin or both. And what she found was that, and I'm just talking about the endometrial work, but it is definitely apparent in oocytes as well, that when you have glucose, you hyperglycosylate your enzymes within the cell, but when you add insulin, it's additive, it goes much higher, and then you get a lot of sugars within the cell cytoplasm, and they hyperglycosylate all your enzymes and make them go really slow, so that you need a lot of ATP, and every time you make an ATP molecule, you get a free radical, which is an electron, and that damages the cell, and that cell's a vulnerable cell then. It's more likely to be apoptotic and to die and create an inflammatory immune response. And she actually showed that the placentas were smaller, and also there was a lot of inflammation. We also know this from other people's work, and this is a group from America called Vega. And they cultured primary torofibroblasts, which are placental cells, in culture in a sugar-containing medium, but they added insulin. And what you could see here is that when you added insulin, when you had insulin, that middle layer there, you got a lot of caspase 3 is a marker of apoptosis. This is a marker of DNA damage, and this is cell survival. They looked at cell survival as well. And so you had a lot more DNA damage, a lot more apoptosis, and a 66% reduction in cell survival. And what happened was when you pre-treated with metformin, or then used it, you got recovery. So metformin's quite useful in cell cultures of placental cells, and we're increasingly thinking that this is a good treatment to help the cellular health of your placenta, but we're also seeing it in oocytes, fragmented oocytes, and also many women who have high insulin. The symptoms are sugar cravings, and also people don't like exercising because they can't retain sugar in the blood very well. It goes straight into the cells if the insulin's high, so you can't get it out. So when you exercise, you feel pretty bad for a while because you get a bit hypoglycemic and you're always kind of wanting sugar. And often they marry people or partner with people who like going out to dinner and not on 40-hour hikes. So quite often the men have it as well, and that really impacts on sperm quality, and we're thinking also fertilization and fragmentation, particularly between day 3 and 5. So we wanted to find out if the Tregs were affected by high insulin. So we looked at our miscarriage cohorts and changed them from people with high insulin, compared people with high insulins to those without, using some multicolored flow cytometry. And we looked at we actually looked at HOMA-IR in this, but it was also consistent with the 2-hour insulin. And we asked if we would see any T cell changes, because T cells would then change how the placenta grows and how they develop. And what we found, this is the demographics, the BMI wasn't high in most people. The age was fairly young. Everybody had between 2 and 9 miscarriages, and we had some quite high fasting insulins, but also HOMA-IR was, there was quite a broad range, and certainly some with it quite high. These are the results we got. What we found was when people had a normal glucose tolerance test with insulins, there was, compared to when people had high insulin on their glucose tolerance test, there was a lower proportion of Tregs compared to those who had normal insulin, and the Tregs were less likely to suppress inflammation, so there was a functional deficit as well. And when we measured the cytokines and looked at various IL-8, some of the inflammatory cytokines, they were much higher when the insulins were higher. So our working theory is that insulin resistance alters the Treg phenotype in recurrent implantation and miscarriage, and that it reduces proliferation. The Tregs have reduced proliferation, activation, reduced suppression, and decreased memory, and they're fairly naive. So we believe that the Tregs are being used up very quickly to manage this inflammatory environment, and that you get a lot of growth of new ones to try and control this inflammation. And then you get a pro-inflammatory environment, and that impacts the health of the embryo when it implants. It just can't get the vascular supply it needs, and the cells don't grow as well. And currently, we actually think it's impacting much later in pregnancy. We've been measuring insulins in people with later losses, mid-trimester losses, and often the insulins are high as well. And so we're working on some research now to try and look at bigger cohorts to be able to prove this. And we're thinking that this impacts on pregnancy. And that we have an opportunity as IVF doctors to help people get through to 39 weeks in a way that we've never thought of. I work with these amazing people. So Sarah's been working in reproductive immunology for a long time. She's an incredible font of knowledge. But Dee McCormick did a lot of the miscarriage cohort work on the insulins, and she was the one that really found it was really high a lot of the time. The other caveat to everything is if you Google hyperinsulinism and almost any medical condition, there's often an association. And it's associated with 13 cancers, it's associated with dementia, memory loss, kidney, liver. What diabetes does really, but it's not as severe as diabetes. And just in the latest Economist article, there was a big article on longevity, and it was about metformin. And I think it's about hyperglycosylation of cells and cellular health. And when we have high insulins, that gets impacted because the sugars get driven into the cells very easily. So thank you very much for listening, and I hope you found that interesting.